I'd like to address the topic of cracked teeth. How do we diagnose them? How do we make our decisions? And how do we have a treatment plan that we can depend on? Cracked teeth. Coronal fractures can be managed conservatively. Quite often, just placing a full crown if there is not a full crown on the tooth. And if the symptoms are of a reversible pulpitis. Okay, so every time your patient bites on it and flexes the fracture segment, it's going to stimulate the pulp inside. It's going to injure it a little bit. But if we have transient responses, it can be quite sharp. It's classic that we have a sharp response, but a transient response to cold, no aberrant responses to cold, to heat, then we have a reversible pulpitis by our definition, our pulp testing definition. And if this tooth has a full crown on it, it's a different situation, but if it does not have a full crown, then we're going to cut the tooth, prep it, full crown with temporary cement. Because once we set the full crown on the tooth, those fracture segments will either be immobilized or they won't. If we place a crown on the tooth with temporary cement and the next day the patient bites on it and it's comfortable, then we know we could probably cement the crown permanently, assuming in a month or two the pulp is still vital. If we put the crown on with temporary cement and the next day the patient bites on it and still has that sharp transient response of the crack moving, then we need to do a root canal. RCT if bite symptoms persist after the crown is placed. Okay. So to reiterate, if it doesn't have a crown, we're going to consider putting a crown in place with temporary cement if it's transient sensitive to cold, if we feel like the pulp has a chance of surviving. We're going to set the crown. Don't tell the patient not to expect the tooth to feel more comfortable with a temporary crown on the tooth because it will flex and the segments will move. It's the rigid cast unit that needs to go on. Also, don't recommend full glass. I know the theory, it doesn't work. They break. We need, these are all patients that brux heavily on their teeth. We need porcelain fused to metal. Okay, let's talk about a different direction here. If the tooth has a crown on it, how do we determine that it's fractured? Okay, crown tooth with cracked tooth syndrome. How do we know that it's a crack? First off, we look at the history. If we treated the patient before the crown was placed, or we call the patient's previous dentist and ask, was that tooth cracked before you placed the crown, that will get us a long way to the diagnosis. But mainly, like every other diagnosis, we're going to do the same thing that the patient does to stimulate it. We're going to do the bite stick test. And this is critical here because it's a crown tooth. You're not going to be able to transilluminate and see a fracture line. Transillumination is helpful, but not really diagnostic unless it is coherent with all the other findings. Bite stick, if we bite on the tooth and commonly on release, pain on release of pressure is pathognomonic for cracked tooth syndrome. Another crown on the tooth, if this is a full crown, is not going to make the tooth feel better. This guy needs a root canal, assuming there's no signs. If no signs of root fracture. Okay. When we enter this tooth, so it has a crown, we know that we're going to have to do a root canal if there's no signs of root fracture. First thing we're going to do is confirm that there's no signs of root fracture. And what that looks like is this. If we, let's say we're looking at a lower molar, the crack goes over the mesomarginal ridge, and here's the access cavity. We've got the mesial buccal and the mesolingual here. Here's the pulp chamber floor. We might see those little lines in there. Here's the distal. It's hidden from us, and we see the tooth around it, and there's this little cracked line over the mesial marginal ridge. Classic, okay? We have the adjacent tooth here. And if we break the contact with the burr and we probe along there, we're looking and we will see the crack extending down. We want it to stop short of the pulp chamber floor. That means it's a coronal fracture, not a radicular fracture. However, we have limits to how finely a crack we can see. So if it's not restored, I'm going to use a diamond to break the contact. I'm going to probe along here, and what I want to find is I want to find that it's the same depth adjacent to the fracture line on the opposite side, and that when we get to the fracture line as seen on the inside, that it does not drop down deeper right there. If it drops, if it's 3.33 and it goes 4.5, almost certainly you have a cracked root, and this tooth has no decent prognosis and should be definitively managed. It should be extracted and replaced with an implant. Let's talk about the signs of root fracture. Now, I just showed you about breaking the contact and probing along there. Radiographically speaking, what we're looking for is usually we're looking for crestal breakdown. And we want to see that nice crest here leading down the PDL on both sides. If we have a crest that looks like this, then it's a no-go. This almost certainly is root fractured. If you see this and defect developing here, or even worse, you see angular defects mesial and distal, it's a root fracture. If you see an anterior tooth, and when you probe it, you find a deep pocket on the two opposite sides of the tooth, there's only one reason for that, is the fracture plane goes through there, you've got a pocket on the opposite sides. Relatively, I've never seen opposing pocket, I've never seen lesions developing exactly across from each other in probable pockets on exactly the contralateral side of the tooth in any situation except a root fracture. One other comment I'd like to make about diagnosis with pulp testing, cold and heat pulp testing, is we need to be very aware of the presence of NSAIDs on board our patients' bodies. If we have anti-inflammatories like ibuprofen, like Aleve, honestly, just one 81 milligram children's aspirin, sometimes even Tylenol, but it's not as effective. But any of these, if they've taken any of these in the time frame that they're still effective in the patient's body, you will have normal cold and heat test responses quite often in pulps that have dying pulps, in teeth that have dying pulps. So when your receptionist hears an incoming call, the patient says they're having a pulpitis or something that sounds like a toothache, your receptionist needs to make sure to ask, have you taken any pain medications, anything at all? This is a 6 hours that we need to wait. This is 12 hours. This is probably 6 hours here. Tylenol the same. So it's easier if they've taken ibuprofen and they call you in the morning, you're just going to see them at the end of the day. If they've taken leave and that day, you're going to tell them to take a big dose at 8 o'clock that night and then come in at 8 o'clock in the morning when this is worn off, and pulp testing will probably be successful.